Hi guys, I'm Dr. Alan Now from New Jersey, and this month we are hosting the International Society of Cannabis Pharmacists State Series featuring the Big Apple, New York. And today we have Stacia Woodcock. I'll have her introduce herself. She's been in the cannabis industry for quite some years now, and fortunate enough to work for one of the larger multi-state operators, Curaleaf. So I'd love to hear, how your experience from a retail pharmacist is translated to a medical cannabis dispensary. And we have a lot of topics to touch on, especially with pending legalization in New Jersey, New York. As the Northeast shifts to an adult use market, what that's going to mean for medical patients. So a lot of information tonight. So we're glad to have you here. All yours.
Thanks so much for having me. It's always a pleasure. As you mentioned, my name is Stacia Woodcock. I am a doctor of pharmacy. I received my PharmD from the University of Kentucky. Have a history in both retail and specialty pharmacy, primarily specialty, building MTM programs, working on STARS outcomes and helping with URAC accreditation for specialty pharmacies prior to getting into cannabis. I started working with Curaleaf in 2018, I believe. Yeah, it's been almost 3 years. In New York, I started out as the director of practitioner outreach, then was the assistant director of dispensary ops for New York. And then most recently, I'm running the Queens dispensary because of COVID and all various and sundry things that go along with it. So I'm actually have been in the dispensary for about a year, which has been awesome. I've really enjoyed interacting with the patients. I think, it's always interesting to hear how different people get into cannabis. And for me, I had done, when I worked for Walgreens, I had done a lot of their media integration. So a lot of their on-camera work. I was sort of the pharmacist on air for Walgreens. And so I got a lot of visibility from that. And one of my former supervisors became the director of dispensary operations for Curaleaf in New York. They realized pretty quickly they needed a pharmacist who could speak to practitioners, who could educate them on the program and get more patients certified. And he immediately thought of me. I was living in Salem, Massachusetts at the time. And he reached out and was like, hey, what would you think about relocating to New York and working for a cannabis company, which was not at all what I ever expected to do with my career. But once I came down and started educating myself on cannabis and seeing the outcomes in patients, I realized that all of my MTM skills really translated pretty beautifully into the cannabis industry. We were doing a lot of what MTM is about, reducing polypharmacy, getting patients off of multiple prescriptions and onto one thing to manage their outcomes, using lifestyle modifications along with pharmaceuticals. So it was a really great fit for my skill set. Made a lot of great connections in that first year. And it's just been not smooth sailing. I mean, it's cannabis. It's never completely smooth sailing, but I've been enjoying my job so much more since shifting over to cannabis. So it's been a wild ride so far. I'm kind of excited to see what's going to happen next as things sort of change. So I think this is the pretty standard outline for speaking through each state. We're going to talk about the process for patients to become certified, what the program currently looks like, what the pharmacist's role is within the program, and continued resources for staying updated on outcomes. So the certification process in New York is a two-step process. First, the patient has to be certified by a qualifying practitioner, and I'll get into what that means, I think, in the next slide. After that, the patient then has to register their certification with their individual account with the Department of Health, and that's when they receive their medical marijuana card. So they have the certification from the practitioner, their registered medical marijuana card, and with those two pieces of information, they can then come to the dispensary. Patients are not limited to which dispensary they go to. They can go to all of them if they want, or they can go to just one. There's not a limitation as far as, whatever the first one is that they choose, they have to stay with. So they can kind of dispensary hop to choose the different products that each dispensary carries that they like the best, which is kind of nice, the way that the program works. So we do have a list of specific qualifying conditions in New York. We are considered one of the more restrictive states when it comes to qualifying for cannabis because all of the conditions must be accompanied by wasting syndrome, severe pain, nausea, seizures, muscle spasms, PTSD, or opioid use disorder. So that gets challenging sometimes for practitioners to feel comfortable certifying patients because they're worried about getting in trouble if they sort of venture outside of the really specific conditions that are on the list. Most commonly, we see patients get certified under chronic pain, neuropathy, PTSD, and inflammatory bowel disease. Those are the four most common that we see within the program. Cancer being probably a close fifth for those main four. And then obviously we do see patients with sort of the more rare diagnoses like multiple sclerosis, fibromyalgia, things like that. So it really runs the gamut what patients come in for. It also varies widely. You know, if they see a telemedicine provider, they might be a little bit more lenient on the qualifying conditions than, you know, a pain management specialist or oncologist might be. One of the interesting things about the New York program is if a practitioner is certifying a patient for substance use disorder, the clinician has to have a Federal Drug Addiction Treatment Act of 2000 waiver on file with the state. So they're only letting clinicians who are fully qualified within the substance use disorder space to certify patients under that designation, which is good. I mean, that is as it should be, I think. So as far as which providers can certify patients, all MDs, DO, and NPs are allowed to certify patients. Physician assistants are also allowed to register as long as one of their registered supervising physicians provide authorization and are also a registered provider. All practitioners have to be qualified to treat patients for whatever condition they're certifying them for, and they have to be in good standing with the state board. In order to become certified, practitioners have to complete an approved educational course, and there are only two. I guess technically there are three because the answer page offers a 2-hour and a 4-hour, but it's either the answer page or the Medical Cannabis Institute. Those are the only two that the state has currently accepted to offer. They were taking applications for new providers because I don't know if any of you have done the answer page CE, but it's not very useful. But because of the changes in the program, they've put a stop to that right now. So hopefully once all of the new legislation comes about, we'll have more educational providers. But right now, these are the only courses that are offered. Practitioners can take any of the three. Dispensary staff have to take the 4-hour course. They must take the more robust of the offerings, but clinicians can take whichever one they want. Once they take it, they register with the Department of Health, and then they can choose whether they're put on a registry list that's on the Department of Health website. And they list all the certified practitioners by their county of practice and their specialty. So if you live in Queens County and you're looking for a neurologist, you can go on the state website and drill down to find a provider in your area, which is great. Telemedicine is also allowed. So we do have some of the, pay for play operators like Nug MD, Presto Doctor, Indica MD, things like that, that offer a little bit more affordable cost, which has been nice, particularly during COVID when a lot of doctors weren't able to see patients. Telemedicine has been really helpful for helping the program to grow. So the price of the certification is completely at the practitioner's discretion. I think the cheapest that I've seen is around $99 for a year certification. We do have some practitioners that charge $200, $300 every few months. And that can be challenging, obviously, for a lot of patients to afford. And, obviously, when we have practitioners that understand cannabis medicine thoroughly and they're giving really thorough care, it makes sense that they want to follow up with the patients more often. But sometimes it does feel a little bit extortionary, the way that some of them charge patients for the certification. And they aren't very open about the fact that that's their choice to do a short-dated certification, which we'll talk about later as well. But the price can be there's a huge fluctuation. I think by and large, we're probably the most expensive state to get cannabis certification. I know in a lot of other states, it can be like $30 or $40. So this can be a huge barrier to entry for a lot of patients when it comes to getting their certification. And I may have mentioned this on a later slide, but what the Department of Health sort of did as a response to that was they put some really clear direction on their website for insurance. And basically, if the practitioner that's certifying the patient is seeing them for primary or specialty care and certifying them for cannabis as part of their ongoing treatment, then they can bill the insurance for that visit and charge the patient a copay. The only time that practitioners can't bill insurance is if they are only seeing the patient to certify them for cannabis, and that's it. So if you're going to a one-stop shop to get your certification, you're going to pay a lot more out of pocket. It's to the patient's advantage if it's your primary care or specialty doctor that's in charge of your ongoing care. If they are registered and able to certify you, then it's a insurance copay just like any other visit would be. So we've done a lot of education to practitioners to help them understand that, because we'll have a lot of doctors who are uncomfortable about liability and things like that. So they're fine with their patients using it, but they don't want to certify them themselves. So they'll send them out to these one-stop shop or these pot docs who charge a lot more, because they don't understand that if they did it, they could just charge a copay. It'd be so much better for their patients. But on the other hand, we do have a lot of doctors who adopted it as part of their practice. And it's been really great to see, their patients get the certification. They don't have to pay any extra. And they can just come in like they would to the pharmacy to pick up their prescription. So there's a huge variety of how the program is being used throughout the state. So the certification itself can last up to a year. It's at the practitioner's discretion. And I'll show you an example certification later and show you exactly how the practitioner does that. If they choose to short date it, the patient has to go in and see them, pay them again, and then they can just update it. But they are allowed to issue the certification for up to a year. In cases of terminal patients who are in hospice, they are allowed to have a certification that does not expire. Usually that's because they don't expect them to live longer than a year. But in often cases, they may not be able to come back and get recertified after a year. So if it's a terminal patient, the practitioner can designate that on the certification and then it won't expire. But that's the only exception to the expiration rule. As far as limitations to products and ratios, that's completely at the practitioner's discretion, how they want to issue the certification. And again, I'll go into that when I show you the example, so it's a little more clear. And we do not accept any other state cards. So if it's New York, we have a lot of snowbirds who live in Florida. They see Curaleaf in New York and Curaleaf in Florida. They think they can go to both, and you can't. So they have to get a separate Florida card with their Florida residency and the New York card with their New York residency. There's no reciprocity between states. Other states do take New York medical cards, but New York does not take any other cards, at least right now. That may change with the new adult use program. So this is what I was mentioning earlier about insurance, and that does include Medicaid patients. So the state has been very clear that Medicaid patients are part of that insurance covered group. So if they're a Medicaid practitioner, it certifies them. They do not have to pay a copay for that. And so they can incorporate medical cannabis into their care. The other thing in New York that works well is that workers' comp will reimburse for the cost of medical cannabis and also for the patient's travel to and from the dispensary. And we've had great success with that, with working with workers' comp practitioners to get patients on cannabis instead of opioids. They get reimbursed for the cost just like they would for their prescriptions, which has been a huge win, I think, for the New York program. So this is what a certification looks like. It's a full sheet of paper. The certification number is in the top right-hand corner, and that's what the patient uses when they log into their account with the Department of Health to link the certification to their account. It has all of the practitioner's contact information at the top, and then the patient's information in the middle. you can see the doctor has to input what the patient's qualifying condition is and then what their associated condition or symptom is with that, which is great because when they come into the dispensary, we can see exactly what they've been certified for. 9 times out of 10, they have 4 or 5 other things that aren't on the list that they also want to get treatment for. So we still have to have, a full conversation, but at least it helps guide the conversation or helps us know where to start. The temporary resident field, we do have patients, just because we have such high level cancer care centers and things like that in Manhattan, we'll have patients that live elsewhere that are temporarily in the city for treatment, or in the state for treatment, I should say. So you can get a cannabis certification if you are not a New York resident. The doctor just has to indicate that you're a temporary resident, and they have to tell the Department of Health what you're getting treatment for and why you're here, and then you're able to get your certification. These are very, very rare. We don't see them very often, but particularly from like Memorial Sloan Kettering or the bigger cancer centers, we do see them occasionally, particularly with people from New Jersey who get treatment in New York City, just because they're so close. So a lot of times we're able to still get them a New York certification so they have access to our products. The incapable of consent field, that's for proxy applications. So we are allowed to have children certified in the program. So that would be incapable of consent, obviously, or if you have a disabled adult. We have a lot of autistic adults that get therapy, and so their caregiver or parent will become the proxy applicant, and the doctor will put incapable of consent so that the person that's their caregiver can complete the application for them. Again, not super often, but it does happen. And then all of the meat of the certification is under the dosing recommendations. We are required, every dispensary is required to have 3 different ratios at all times: a high THC, a high CBD, and an equal ratio. Because of that, the doctor is allowed to put up to 3 different dosing recommendations on the certification. So they could put in one for high CBD, high THC, and equal ratio products. The majority of the time, doctors just put in one, and they put no preference and per pharmacist on everything. That's the other huge differentiator in New York. We are required to have pharmacists in all of our dispensaries. So it's nice for the practitioners. They can just put per pharmacist, they send the patients to us, and we do all the heavy lifting. But the practitioner does have the option of sort of honing down what the patient has access to through all of these different fields. So say, for example, it's an oncologist who has a lung cancer patient and they don't want them using any inhaled products. Under form and administration method, they would put oral and sublingual, and that's it. So that means the patient would not be able to purchase inhaled products. Same thing under the ratio. So right now it says per pharmacist, but the practitioner could put 1-to-1 ratio only. Whatever they put in that box is whatever, that's the only thing the patient can purchase, and that links through to our BioTrack sales system. We can manually override it, but you can't do that without a note from the doctor. So, it definitely flags the associate that's ringing the patient up that they're not supposed to have access to those products. And then under recommendations and limitations, a lot of our doctors, they don't want to limit patients, but they do have guidance for the pharmacist. So this is where they'll put their notes. So they'll put, start with 1-to-1 during the day and high CBD at night, or, start with a long lasting dosage form for maintenance and inhaled for breakthrough. So whatever it is that the doctor thinks is the best place to start for the patient, they'll often put that in the recommendations, just so that we have open discretion as we move through the patient's treatment. It doesn't limit them, and we don't have to contact the doctor constantly to update the certification, and they can just put their notes. So all of this can be changed. So anytime we have a limitation and the patient needs a change, it's just like changing a prescription. We call the doctor, ask for their permission. They log into the practitioner side of the Department of Health program, and they go into the patient certification and they can make any changes they need to make. So they can add a dosing recommendation, they can change a ratio or a limitation at their discretion. So they can do that at any time. That also means, if the patient is supposed to come in every 3 months and they haven't paid their bill, the doctor can cancel it, and they'll come in and we won't be able to sell to them because it'll come up canceled. And it does not alert us when a change has been made. So that can be a little tricky. We usually scan the certification when the patient comes in, so that we can track any changes, and we're able to put, constant ongoing notes as we communicate with the practitioners. And that really helps us sort of see when changes are made. The other thing that's really confusing to patients is that at the bottom, the certification issue date and expiration date that's highlighted in blue, that's always 1 year, because the certification always expires after 1 year. What gets tricky is that underneath the dosing recommendation, the doctor can change that date to their discretion. So this dosing recommendation also lasts the full year of the certification. But if we have a practitioner who, say, likes to see the patient every 3 months, they can change the end date of that dosing recommendation to February. And after that date, the patient won't be able to purchase. So they'll have to go back in and see the doctor. And then the doctor will put in a new dosing recommendation for the next 3 months moving forward. And so they can continue to do that until the expiration date of the overall certification, which is 1 year. But that gets really tricky for patients to read and understand, because they see that highlighted expiration date and they think they're good. They don't look at this little end date on the dosing. So it leads to arguments sometimes and some confusion. So it's just one of the challenges of the program and the way it's set up. And it's also confusing to them because they don't understand why a doctor wouldn't let them have the prescription for the full year, particularly when, they might have friends or family that do have a full year certification. So that can be challenging to explain as well. But it's always up to the practitioner's discretion and how they choose to take care of their patients. So once the patient gets the certification from the practitioner, they have to register it through the Department of Health, and that's how they get their medical marijuana card. It is not a very user-friendly program, so we offer registration assistance in our dispensary. We have a lot of patients, particularly elderly patients or those that aren't as computer savvy. They bring their certification in, they think that's all they need. It does come with 2 sheets of instructions that are pretty detailed, but a lot of times the doctor forgets to give it to them, or they just throw it away and they don't read them. So they forget that second step is necessary. As long as the patient has a New York State driver's license, that registration is immediate. They'll get a temporary card that they can immediately print out and use right away. So as soon as they register, they get their temp card, they can come into the dispensary. If they don't have a New York State driver's license, or if, say, for some reason, the doctor put in their updated address and their old address is on their driver's license, any sort of discrepancy between the certification and their ID, that takes longer because they have to submit proof of residency, proof of whatever that change is to the Department of Health, which then has to be reviewed and approved before they're going to get their temporary card. So sometimes it takes longer, but most of the time the certification registration can all be done in 1 day, and then they can come right into the dispensary. And then they get their permanent card within a week. The permanent card does have a photo on it, so it serves as a photo ID. What the temporary card does not. So whenever a patient has a temporary card, they're also required to have a photo ID to come into the dispensary so we can verify the patient's identity. There was supposed to be a $50 registration fee for the registration process, but that's never been implemented. It's been waived since the beginning of the program. And the program, I think medical cannabis was approved in 2016 in New York, and the first dispensaries opened in 2018. So we're 3 years now, and they've never charged a fee. It's just been waived since the beginning of the program. So as I mentioned, the products that are available, we are required to have 3 different ratios on hand at all times. So we have to have a high CBD, an equal ratio, and a high THC. New York does the ratios backwards from the rest of the country. They put THC first and CBD second, which again can cause quite a bit of confusion for patients who live in different states or come from California and are used to it being the other way around. So we do a lot of education around that. And typically when we refer to products, we don't refer to them by the numbers. We refer to it as high THC, high CBD, and equal ratio, just because it can get really confusing. It's one of the frustrating things about the way New York does things is, they always want to be different, but that causes some confusion because we obviously don't have any sort of federal oversight into how we talk about products. So we are not allowed to have whole flower in New York. All smokable forms of cannabis are prohibited. Ground flower is allowed. And Alan and I were talking about this earlier. Whoever was in charge of this particular line in the regulations, they thought that if flower was ground, it could not be smoked. So somewhere in Albany, when they were making these regulations, someone who clearly did not understand cannabis was making decisions. So ground flower has been allowed because they think it can't be smoked, even though it can. But we are not allowed to talk about smoking cannabis in the dispensary. We can only talk about vaporization. We're only allowed to carry devices for vaporizing ground flower, which I'm behind as a clinician. I don't think smoking is good for you anyway. I would always recommend vaporization. But it's a really interesting legislative nuance. And I think it points to the gaps between legislation and the actual working within the industry. There's obviously some pretty massive knowledge gaps when you have things like this get passed, just because there's a full lack of understanding of how the plant works and how it can be consumed. Along with no whole flower, we're not allowed to talk about strain names or terpenes. So we can tell patients when they come in what strains we have in stock and what terpenes are in them, but we cannot put them on any of the labels of the products. We can't put them on our menus. We can't use them in any of our marketing. We can just talk about flower. So that's really interesting in New York, the way that it works. But I think, by the same token, there can be a lot of fixation on strain names and not on ratios and effectiveness and potency. So, I think it's more successful to not always have to have those conversations or have patients who are specifically looking for, one strain without having a bigger conversation about why that strain might be more effective for them as far as what it contains. But, it is what it is for now. We're also not allowed to have edible products. So no brownies, chocolates, we can have gummies, brownies, chocolates, food products. We were able to get chewable tablets and chewable gummies approved by the Department of Health, as well as mints and lozenges. And that was purely from a patient access point of view. Once we sort of explained that, if we have pediatric patients that can't swallow capsules or don't have a patient who maybe has ALS and doesn't have the motor coordination to be able to hold something under their tongue, we need these products for patient accessibility. And so we were able to get some of the more medically oriented, edible products approved, but nothing that's food of any kind. We're not allowed to do anything like that, at least as of right now. We're also not allowed to have any sort of concentrates. So no wax, shatter, dabs, the really concentrated forms of cannabis. And that's primarily because there's a formulation limit of 10 milligrams of THC per dose. So all of our products can't be formulated with more than 10 milligrams of THC. So the strongest capsules that you'll see have 10 milligrams of THC. And usually it's around like 9.5, 9, something like that. As opposed to other programs where you might see 50 to 100 milligrams of THC, we are not allowed to have products like that. And with all of our inhaled dosage forms, it's like a 2.5 second inhalation delivers 5 milligrams of cannabis. So we would never be able to give a dose of an inhaled product that delivered more than 10 milligrams of THC. And that all, also affects the day's supply of our products. So even if we have a patient who's using 50 milligrams of THC a day, we still have to go by 10 milligrams of THC per dose when it comes to our days of supply, which can be challenging for patients to get what they need for a month because they do have a purchase limit of a 30-day supply, and it's a rolling 30 days. And there's a 7-day buffer, really similar to controlled substances, or at least the controlled substance law in New York, that we keep track of their purchases. All purchases are uploaded into the PMP. So if they go to another dispensary and purchase products, and then they come to Curaleaf and purchase products, I can see exactly what they've purchased everywhere and be able to calculate the days of supply they have and what they're allowed to purchase at my dispensary that day, which is great. I think that is as it should be. It gives us transparency into where the patient's going, what they're doing. It also helps us see, like, if they're only getting vapes from us, but they're using longer acting dosage forms from another dispensary, we can have conversations about, why are they using that product versus our product? Is it a formulary thing? Is it a taste, effectiveness? And it helps us get feedback from the patients as what works for them and what doesn't, which is great. So as of June 15th, it's the last time, I think they update the website on a weekly basis. There were 3,260 registered practitioners in the state of New York and 151,478 certified patients. For a state as big as New York, these numbers aren't fantastic. When I first started, the practitioners were around 1,500. So we've seen that double over the past couple of years, which has been tremendous progress, but I think we still have a ways to go. And part of the reason for that is that there are only 10 companies that are licensed in New York State. We are all required to be vertically integrated, so we have to grow, manufacture, and dispense our own products. We are allowed to wholesale between one another. So Curaleaf is a vertically integrated company in New York. All of the other companies can purchase and sell our products in their dispensaries, but there are no individually licensed growers or manufacturers. It's only the vertically integrated companies that can produce and sell to one another and can open dispensaries. Each company is allowed 4 dispensaries for the state. So we operate as Curaleaf 4 dispensaries in New York State. And the Department of Health determines where that dispensary is located as far as what county. So they assign the county, and then within that county, we're allowed to choose our own location, but we don't get to open wherever we want. The Department of Health wanted to ensure that as much of the state was covered as possible, so we're pretty widespread. Curaleaf has a dispensary in Plattsburgh, which is really close to the Canadian border in the tip top of New York. We have one in Orange County, which is north of New York City. We have one in Queens, which is our, Manhattan 5 boroughs dispensary. And then we have one out on Long Island. We are allowed to deliver. So right now we deliver to the majority of New York State. We have a really robust delivery program. Not all dispensaries deliver. Not all of them have the resources to do that, but we are allowed to provide delivery. It's not same day delivery, so it's not a Uber Eats situation. We have to give the Department of Health our manifest 48 hours in advance. So it's an advance order delivery system, but it's been great for our patients who don't have transportation. Again, during COVID, people were afraid to leave their homes. We were able to get their medication to them in a way that was safe, which was great to help expand the program for accessibility purposes. But when you look at the entire state, that means right now we have 38 dispensaries open. So 2 of the companies still have 1 location that hasn't opened yet. And that's 38 dispensaries for the entire state of New York. I think there are 38 pharmacies in my neighborhood alone, much less, the entire state of New York. And that means there's only 1 dispensary for about every 500,000 people. It's not nearly enough. It can be really challenging for patients to have access to cannabis in their area just because there are so few dispensaries open within the state. Obviously, hopefully that's changing as we've passed new legislation, which I'll talk about. But that's probably the thing I'm most excited to see is the expansion, more dispensaries so that more patients have access and it's not so challenging for them to get to. The Department of Health, I think I left this off the slide, but they also determine the pricing, or at least the base pricing of cannabis products, but there's a huge disparity between companies. So it's changed over the past year. I think a lot of the companies that were charging excessive amounts for medication understood that, they weren't going to get patients that way. It was great for us because we have the most affordable prices in the state, but we're starting to really force those prices to come down. Because, if you have a patient that's on Medicaid, they already have to pay $100 for their certification, and then they're paying $100 to $200 a month out of pocket for their medication. That just becomes unfeasible for them as an alternative. So that's the other thing I'm excited to see with the new expanded legislation is pricing come down. So we recently passed both adult use cannabis, as well as expansion of our medical program. The medical expansion allows for whole flower. It also expands the qualifying conditions to include autism, Alzheimer's disease, muscular dystrophy, rheumatoid arthritis, and any other condition certified by the practitioner. So that means it's open. The doctor can certify for whatever they think might benefit the patient, which is going to be huge for us. Again, for liability issues, we have so many doctors that are just super hesitant with that limited list. And so this open qualifying conditions is going to be great. Doctors can start to certify patients for whatever they think might benefit them. And it also, it means that we'll have more patient access, as well as more practitioner adoption, more data that we can use. And the expansion also allows patients to purchase up to a 60-day supply of medication. So not the 30-day limit, they can purchase up to a 60-day supply. So again, when you have someone that's driving 2 hours to get to a dispensary and they have to do that every month, that can be, prohibitive. So if they're able to just do that half the time, then that's great. They can get their 2-month supply and be good to go. The downside of all of this is that the adult use and medical expansion part of that legislation changed who manages cannabis in New York. So previously it was the Department of Health, and moving forward, they're going to have a new Office of Cannabis Management. And because of that, the Department of Health has no interest in taking on any of the medical expansion. They're basically like, it's not our deal anymore. So you have to wait until the Office of Cannabis Management is up and running, and then they'll take care of it. So all of these changes were supposed to be immediate, and none of them have been implemented. We're not allowed to do any of them, and no changes have been made. So a lot of the ROs, as well as the practitioners, are really frustrated because they want this expansion to happen now, as it should have. So there's been a lot of push and pull with our state government to try and at least get the medical expansion implemented while they're figuring out all the logistics for the adult use program. So the pharmacist role, in New York, pharmacists have to directly oversee all patient consultations. The dispensary is not allowed to operate without a pharmacist present. So very similar to a pharmacy, even though the Board of Pharmacy has no involvement at all. They cannot operate and run unless there's a pharmacist on site at all times, which is great for us because it's a new exciting role for pharmacists in New York. All of the dispensary pharmacists have to complete that 4-hour course that's approved by the DOH, but it's a one-time program. There's not any CE or ongoing education. You do the course one time and that's it. You're good to go. They send you off to run a dispensary. Which can be challenging because, as I mentioned, the course really does not prepare you properly for your role in the dispensary, particularly because there are so many practitioners that aren't educated in cannabis and they're trusting us as the pharmacist to really oversee their patient care. So there's a lot of self-education that happens. I think all of the dispensaries have their own education programs for their pharmacists. But, it's great for me because it means, I can block out an hour and a half for every consultation and do a full MTM workup, look at all their medications, look at their health conditions, and talk through their treatment plan and formulate that for them. And I have the time and the discretion to do that all day, which is amazing. So I actually am doing what I always wanted to do, and it's the requirement of my job in the dispensary. And I think, from my perspective, obviously I haven't worked in another state, but I've seen how different states operate. And I think that there's a huge level of trust for the patients. Like they come in and talk about their medications and I'm like, oh, that's for this. That's for this. Are you taking this? And they're like, how do you know this? I'm like, I'm a pharmacist. They're like, oh yeah, I forgot. I understand their disease states. I understand their comorbidities. I understand, how everything is going to fit into their current medication and lifestyle in a way that I think, a lot of dispensary associates wouldn't be able to. But then I'm also educating all of my staff. So they listen to me, they sit in with me on the consultations. I do a lot of training with them. So they're getting the benefit of my expertise and knowledge as well. So at the cash register, when they're having those one-off conversations, they can use that to inform the way that they're speaking to patients and guiding them. So it's a win-win on all counts. I think, from the feedback we've gotten from patients, our patient retention is crazy good because they get that heightened level of clinical care in the dispensary. A lot of the registered organizations also use pharmacists to do outreach. I mean, that's how I came into the program. There's a huge need for education. And as we all know, doctors are much more likely to sit down and talk to a pharmacist than they would to just someone who works for a cannabis company, because we have that really deep understanding of clinical knowledge and can speak to them on their level and help them understand what we're doing and how it works, and that, we're not damaging people, we're trying to make their lives better. So that's another role. It's not a designated role for pharmacists, but it's being utilized more and more by dispensaries because they see how successful it is in interacting with practitioners. So as far as resources go, the current Department of Health program, that's the link there. And then they have the website up and running for the Office of Cannabis Management. Most of the links link back to the original website. So, as things change, that second website is going to take over and the first one will become obsolete. But until that happens, these are your two best resources to watch and learn how the program is going to change.
All right. Thank you so much, Deja. That was very thorough and very detailed. I have so many questions to unpack. So if there's any members of the audience that want to ask a question, feel free to type in the chat, unmute yourself, whatever it may be. This is kind of like an open forum discussion. But the one thing that I do want to emphasize, if you can go back to that certification screen from your physician. So it seems like the states that require pharmacists to be on staff, like Pennsylvania, Connecticut, New York, they all seem a little more in tune with medical needs of a patient. And this is one of the first times I've actually, I didn't know this previously, that you guys actually have to follow some sort of guidance from the physician. Usually the physicians that I've dealt with either know exponentially less than I do about cannabis, or they're using it as like a last line resort for their cancer patients, for their terminal, chronic pain patients, whatever it may be. So can you walk us through what how you recommend patients based on conditions? Is it based on symptomatic control? And how do you adjust it, even if you say necessarily disagree with the physician that wrote the prescription? Or
Yeah, I mean, I think when it comes to cannabis, there is no one size fits all. So that's where that consultation process is so important, right? I need to know what other medications they're taking, if they have any other health conditions that are going to influence their response to cannabis. So like I might have somebody come in who has chronic pain, they have spinal stenosis, and you would immediately think, okay, they're going to need more THC. But then they're like, I have underlying anxiety and, I'm on an antipsychotic. And then it's like, oh, nope, not going to do that. Right. So you have to look at the whole patient and the whole picture. That's the other thing where like, I have that skill set, right? As pharmacists, we're trained to be able to pull that information out of patients, to ask open-ended questions, and to really like listen and look for cues that are going to guide the conversation that someone who doesn't have that training is not going to be able to do. And so, I'll be halfway through a consultation and think I know exactly where I'm going to go. And then, I ask a question and get something I wasn't expecting at all. And that completely shifts, how I would treat that patient. So that's where that conversation is really important. And it's tricky because, I'm sure a lot of you know this, but the way that medical cannabis can be legal at the state level is through a compassionate use act, right? And practitioners are allowed to recommend it, but they are not allowed to prescribe it. So the more limitations and notes that they put on that certification, the more they're leaning towards prescribing and not recommending. And that puts the practitioner more at risk liability wise. So it gets really sticky because, we'll have certain doctors that will literally write out like 1-to-1 ratio tincture, start at 2.5 milligrams 3 times a day, may increase to 5 milligrams as needed. And I'm like, well, that's great, but you should be careful because you're putting yourself at risk because you're crossing a line that you shouldn't be crossing when it comes to the legal recommendation of cannabis, which, the state decides that it wants to do it how it wants to do it. But I also want to make sure that my doctors are covered legally. So those are always conversations that we have to have. But we do have certain doctors that are really nervous and they will always not let the patient have high THC. It'll always say no high THC, like 1-to-1 and high CBD only. I will always advise the patient to use what the doctor recommends, so that if it doesn't work, then we can come back and say, look, we tried this. It's been a month. We haven't had improvement. This is what I want to try. What do you think? Because I think that's always going to be more successful than this is not right. I think the only time I would ever not follow a recommendation is if they were recommending high THC and there was a direct contraindication that I did not want the patient to have high THC. And that's happened once. And the patient had schizophrenia and the doctor that certified them did not know. And this is the challenge with the pot docs, the one-stop shops. They don't always do their due diligence, and patients don't tell the truth. And so, I asked her for what medication she was on. She starts listing all these things, and I'm like, no, this is not going to work. And I called the doctor, and he's like, oh, I had no idea. And I'm like, yeah, of course you didn't. So, again, these are all things that would not happen if a pharmacist wasn't at the helm of these conversations. And where I see a huge gap for the industry, in assessing patients and properly guiding them. But it makes me happy that we have it here.
Yeah, it's so absolutely necessary. I mean, if you're going to call a medical program medical, you need to have at least a pharmacist, a nurse, or some kind of relevant clinician on staff to answer questions like these. And it's not just about guidance, but it's about intervention. When there are certain groups and populations that cannabis is not the best solution for, we need to be able to dictate that. And that's kind of having this level of control is really refreshing to see. I wouldn't say control, but more like input. Because in other states like New Jersey, where I worked for 2.5 years, patients had full autonomy. You can go through a counseling session. You can recommend, everything to the book, by cross your T's, dot your I's. But at the same time, the patient can go to the counter and just purchase whatever they want, and there's really nothing to stop them. So, yeah, that's great to hear. New York is doing it the right way, I should say.
Yeah.
So Jill had a question about specific labeling requirements, and so if for the broader scope, every state has their own medical cannabis program with their own regulations. But you spoke a little bit about the products in New York. Are there any specific labeling requirements that New York has to have?
Yeah, so we have to have the ratio of the product, the dose of cannabinoids per dose. Like, we can't just put 300 milligrams in the bottle. We need to put like 5 milligrams of THC and 5 milligrams of THC per milliliter per whatever the dose has been designated. So when we have a product, we submit a PBAR to the Department of Health, and they approve it. And all of that information has to be on a patient safety insert that we give to the patient, and it has to be on the bottle, so they know exactly how many cannabinoids, how many milligrams of cannabinoids are in an individual dose of that product. We also have to put waivers and disclaimers about pregnancy and breastfeeding. I believe there's like a controlled substance waiver. There's several different liability waivers that we have to put on all of our products as well.
Right. And in regards to the PMP that you had mentioned before, is that the same PMP that you would use for Schedule II narcotics?
Yep, all controlled substances go into the same PMP program in New York. So that's the other awesome thing. Like, I can see if they're taking opioids or benzos go in there in New York. We treat them like C2s here. As we should. But yeah, so I can see, so if they're telling me, no, I'm not on any opioids, I'll be like, you're not telling me the truth. I see all the stuff that you're filling at the pharmacy. But then it also means I can see they're tapering, right? Like, when we're trying to taper them, I can see that they're reducing how much they're filling. So it gives me really good insight into how things are going and what else is going on.
Right. And you had mentioned calculating a day supply based off of that. Is the day supply calculated based on the physician's recommendation of how much, or is it based on qualifying condition?
No, it's based on the maximum allowable dose. So it's kind of like, it's difficult. Like, so, sometimes we'll put in the dosing recommendation exactly how the patient's going to use it, but most dispensaries use a standard dose for all of their medications. So like for a tincture, they'll put 0.5 to 2 milliliters 3 times a day, and that would be a 2-day supply if they use the maximum. So it's kind of like if they were given a prescription that was like 1 to 2 tablets 3 times a day as needed for anxiety, you're going to use the minimum day supply if they took the maximum allowable amount. Does that make sense?
Yeah, kind of. So it's kind of funny because this ties into our conversation about regulation, about putting potency caps. And in New Jersey, we had the same thing. Like we would dispense cannabis in intervals of 1/8 ounces, right? In eighths, quarters, that was a standard unit, and an eighth is 3.5 grams. And the original regulations were written with a 10% potency, so they took the literal translation, and 350 milligrams of THC was the maximum amount in any product. And it's arbitrary at that point because you can't divide that into doses. So for example, our lozenges come 10 milligrams lozenge, but then it's 35 in a pack, and that's the maximum amount of THC. So calculating dose is really complex because some patients have a lower threshold where they will only need 2.5 milligrams daily, but there's others that can consume probably 100 milligrams and feel nothing. So how do you navigate that type of decision making?
So we always calculate based on the maximum amount they would be allowed to have per day per the regs. So it's kind of like what I was saying before. Say someone has a prescription for alprazolam and it's 1 to 2 tablets 3 times a day. So the max they could take in a day would be 6, and it's a prescription for 30. You'll put that in as a 5-day supply. Now, if they say I'm only using 1 every other day, technically it's a 60-day supply for them, but I'm going to put 5 days when I enter it as a pharmacist because that's the max they would be able to use. You know what I mean? That's like the minimum day supply, I guess you would say, of when, if they use the maximum allowable amount, how quickly they would go through it. So we do the same thing with cannabis. We put in, if they use the maximum amount they were allowed, that's the day supply we give them. Because especially with newer patients, they have no idea in the beginning how much they're going to need, how long it's going to last. And so we always go with the like minimum allowable amount, so that if they go through it faster, we don't have to then, put an override in to give them more if they need it while they're figuring that out.
Interesting. Cool. Okay, so let's shift to a different kind of ballpark about legalization. And this is the main part that pharmacists may not be familiar with, right? Like having restricted access to only medical patients is great, but what happens in these markets when an adult use market comes? Like there's still going to be patients that are using this medicinally, and there's still patients that are going to need guidance from pharmacists. So in states, again, like New Jersey, where we don't have a requirement for pharmacists, it's going to be even more diluted to find really meaningful help from experienced clinicians like yourself. So I know the rules and regulations have not been written in New York yet, but how do you foresee a medical patient medical program staying medical through adult use legalization?
So medical expansion was a huge part of the adult use legislation because they're very concerned with protecting the medical program. They don't want what happened in Oregon or in Colorado to happen in New York. They want to protect the medical patients. They want to protect that supply chain and access, but they're also expanding it because they know that the current program's not working as it is. Especially once adult use gets approved, they want to make sure that medical patients continue to have expanded access. So they're giving all the existing dispensaries additional locations, and they're allowing us to co-locate some of those locations to be both adult use and medical. The pharmacist is going to stay in place within the medical program, and everything should exist exactly as it is. The adult use dispensaries will not be vertically integrated, so they've gotten rid of that. So they'll be able to diversify the supply chain. So you'll have someone that's just growing, someone that's just manufacturing, someone that just is running a dispensary. But the medical program will stay as it is, vertically integrated, at least so far as we know, as what they've said. And the adult use is going to be taxed a lot more heavily. There's a much larger excise tax on cannabis through adult use than through medical. And that's the other reason that they expanded medical to include whole flower, because what they don't want is medical patients going to adult use dispensaries just to get whole flower because they can't get it through the medical program. So they want to maintain that access. But you and I were talking about this earlier, and I hate this division. I hate it within the industry between adult use and medical use. I think it's futile, because if you go into an adult use dispensary and just listen, 90% of the people that are there are using cannabis cannabis medically. They may not know it's medically, but it is. If it's stress relief or to help them sleep or to help them relax or unwind, like that's all medical use. And so not having proper oversight and education to know how to talk to these patients, to know how to guide them, if you just assume everyone coming into an adult use dispensary wants the highest THC possible, you're going to do these people a huge disservice and not give them what might actually be beneficial for them. So, I wish the whole thing were just cannabis and we could have the same training and oversight for everybody, because, it's just so arbitrary. I think, the example I used with you earlier is if we talk about food, we don't say that like a carrot is a medicinal food and a donut is a recreational food. Like it's all food. It all has nutrients. We all eat it, right? So it just seems so silly to me to try and make this division, because cannabis doesn't fall into these neat little piles that way. It doesn't work that way. So we'll see what happens down the road. I think eventually it'll all be a wash and we'll just have, really good dispensaries with really well-educated staff and clinical oversight so that we can serve whoever comes in for whatever it is they need. At least that's my idealistic vision.
No, I 100% agree with you. And that's actually kind of the segue into like promoting ISCPH in the pharmacy role, because in my mind, I will be planning on applying for a dispensary license in New Jersey, but I envision it more like a health center almost, where it's not a pharmacy because I don't have to review every single medication that goes out, but I do want something that is based on, holistic healthcare, functional medicine, being able to integrate cannabis into a healthy lifestyle. And that's possible because of the pharmacist role. Pharmacists have a unique opportunity here to know, to use what they know from a traditional market and kind of translate it even into the nutritional, botanical side of medicine. And all of these things are going to be extremely necessary because, again, even adult use, they'll have access, but that doesn't mean they'll have more guidance. And that's where the pharmacist can really have an extended role. I guess we can wrap up soon, but is there anything that you have on the top of your mind that you're passionate about, that you want to talk about, advocate for? The floor is open to you.
I mean, removing stigma is always near and dear to my heart, especially as pharmacists and as clinicians. I think we have the power to really change people's mindset about cannabis, just like with any other prescription drug. So be an advocate, educate yourself and be an advocate in your community and within your family. I was super hesitant when I first started out to even tell people what I was doing. And now I like shout it from the rooftops, and like everyone I know is a medical patient now because they're like, wait, what? This does what? I can do what? And they're like, how did I not know this? Like, how did I not know this? And I'm like, I know. So I think, we're in a really unique position as pharmacists that we have the people skills and we have the access and we have the credibility to really drive education forward and help legitimize this whole industry just by being advocates in our own personal spaces. So that's the biggest piece of advice I could give to all. Your biggest ask, I would say, is just to really be that voice within your space to help people understand that cannabis is not what we were all raised to think that it was.
Yeah. And I did want to touch on that point about third-party reimbursements too, but we can save that for another conversation. That's a huge market for pharmacists also. Like we're already set up with brick and mortar stores built for insurance billing. So that'd be the next logical step in that process. Mm-hmm. Again, just highlighting some of the potential avenues that pharmacists may have in a role down the line. Well, Stasia, thank you so much for your time. I mean, this was incredible information, and New York is going to be one of the fastest transitioning markets in the Northeast, right alongside us and now Connecticut. Good luck to seeing you, Brian. And so our next month's State of Cannabis series is going to feature Illinois, who they've been adult use for about 2 years and a half now. So I don't know who the guest is, but at the same time, they're going to have a firsthand kind of eagle-eye view of how the medical landscape has changed. So tune into that. That is next Monday. A few Mondays from now, July 12th, same time at 7 p.m. Go to the ISCPH's website. There's a bunch of programs happening, and Melanie is our founder and president, wonderful lady, and she's busy, but She's organized all these events, and she wants us to be actively engaged. So as pharmacists, we can use our knowledge, our experience, and translate it into this new and happening industry, to say the least. So again, Stasia, thank you so much for your time, and have a great night, everyone.
Thanks so much for having me. Have a good night, everyone.